Okay, good afternoon or good evening, depending on what part of the country you're in. I'm Mark Cain. I'm one of the pediatric urologists at Seattle Children's Hospital. I'm going to talk to you guys today about pediatric urinary tract reconstruction, specifically with regards to managing patients or children with spina bifida. And a lot of my reflections are going to be from my time that I spent at Riley Children's Hospital in Indianapolis. I was there for about 23 years, and we were able to collect serial data over kids and young adults for a long period of time. And some of the data, a lot of the data today will reflect the experience that I had there during my tenure. So I'm going to jump right into the lecture. So I have no disclosures at all. And I think what we're going to talk about today are what you'll find as you kind of spend your time in pediatric urology that are some of the most difficult problems that we manage, both in the complexity of the underlying medical problems that patients have, but also the surgical answers, I think, are some of the more technically demanding things. And the long-term risks, I think, also are more complicated than some of the more simple operations we do, and really lifelong. And so I think understanding this from a really broad basis is helpful as we become reconstructive surgeons. So one of the things that's been beaten into me all through my career is that if you look at these kids, what's really interesting is they can have, really evident skin manifestations of spina bifida, like the little baby on the left side of the screen where they've got an external myelomeningocele, or they can have something that's fairly minor, just a little gluteal crease that's offset, and they can end up kind of in the same place from a neurologic injury to the bladder standpoint. And because of that, we actually have to follow these kids very similarly for their entire life, and the approaches we use to manage them are very, very similar. And I think one thing, I've been in pediatric urology for almost 30 years now, and one of the things that I've learned is that timing is everything. So the timing that we intervene is really critical to the long-term outcome, and we didn't really understand that for a long time. And you have to look back at the history of how we manage these kids. Early aggressive catheterization and anti-muscarinics were considered more salvage therapy rather than do it as soon as you can. And I think we've shifted a little bit, and it's going to take another 10 or 15 years to really understand what the impact, but the early kind of findings of early intervention and medical intervention have actually been really good as far as outcomes, meaning needing less interventional type surgery as these kids get older. So we always start with medical therapy, clean intermittent catheterization, anti-muscarinics. A lot of people are doing this really, really early, even in the neonates. Botox is another interesting topic because I think as we've used Botox, it's another timing issue. And I've got a couple slides to show why I think this is the case in the US, as well as maybe in Europe as well. But if you look at this slide, bladder reconstructive surgery, which is what I've spent the majority of my career really studying and trying to learn, is the last thing. So, the goals, I think, of the family are the most important thing. And interestingly, kind of in the mid portion of my career, families would come and just say, I'm ready for surgery. And we never really ask them, what are your goals? What are your expectations of the outcome of surgery? And I think this is really critical as we've gotten to kind of patient-focused outcomes and long-term durable outcomes for the patient as they get older. So establishing what their goals are really important to select the type of procedure that you might discuss with a family. Do they want to be bone dry and out of diapers? Do they just want to be kind of dry enough that they can get through the day so they're socially dry? Do they want to try to have voiding as part of their outcomes? And do they care where they catheterize? Do they have a sensate urethra, or do they have a problems catheterizing through urethra because of their inability to get out of a wheelchair? All these things become really, really important, and we've not necessarily addressed it. And so I've always said life and surgery in general are all about your perspective. So from Seattle, it's the Space Needle, right? So this is looking out the window of my apartment. So if you look out on the left, the nice sunset, the Space Needle looks like a Space Needle. But if you look down on it on a usual cloudy day, it looks like, the invasion of the Martians. So it's about perspective, both as a surgeon and as a family, about how you look at this. And our evolution to get to continence has really changed as we've kind of looked at outcomes. So intermittent catheterization really was fairly new if you really think about it. It's the 1970s that we started catheterizing kids. That allowed us to actually create bladder outlet reconstructive procedures because now you could empty the bladder despite a tight outlet. And then shortly after that, bladder augmentation in kids came about, and everything else is kind of what I consider frosting on the cake. The Mitrofanoff and the MACE procedure let us get to true continence because it let us control the outlet in a different way. Because if you had to create an outlet that was tight enough to be dry but wide enough to catheterize, that left a lot of subjectivity in the middle about how you got there. So I think we're better at that because we now have alternatives. Just another kind of brief historical perspective. If you look at the historical data, there's a lot of holes in it. And I don't think we understood this until young colleagues kind of came with more masters in public health and looking at data differently and questioning how we were reporting our outcomes, because a lot of the data early was really surgeon driven and surgeon evaluated. It doesn't matter what you're evaluating, hypospadias outcomes, bladder neck procedure outcomes, the patients are always going to report better outcomes directly to the surgeons than they are actually living at home. And so really what we want is patient-driven outcomes, and we want really disease-specific validated surveys. And these are expensive to create. We don't have a lot of them because our diseases are uncommon and rare. And historically, the other thing was we use kind of objective data that were just decided upon. Are you dry at a 3-hour interval, or how many pads are you using? Not really based on what is the patient's expectations. So back to the era of reconstruction, and everybody has done these procedures. We don't do them as often as we used to, but augmentation, I just look at this operation as a technical exercise. It's actually very simple: harvesting bowel, reconfiguring it into a reservoir, sewing it onto the bladder. It's actually 2 minutes of pleasure or 2 hours of pleasure followed by a lifetime of pain because these patients stay with you forever and their potential complications never go away. So any kind of new surgical concepts, whether it was a bladder augmentation or the type of bladder augmentation or a Mitrofanoff procedure, MACE procedure, I always look at these as 3 trips around the OR and the journals, because we're going to write about these things again and again. We're academic urologists. We're going to write about how we do it, how we modified it, and why we no longer do it, or how we don't do that one part of the procedure anymore. This is a great historical example. Probably in the mid to late 90s, gastrocystoplasty was thought of as the best bladder augmentation. And honestly, the reason why is most of these patients were coming late to the game for surgery. A lot of them already had renal insufficiency. They had underlying metabolic acidosis. And so it was thought that if you just added a gastric patch, you would create this kind of stable environment where you'd help kind of correct this. Great concept. A lot of them were done early on. The problem was that this wasn't really done in a purely scientific way where we did it in the lab, looked at the outcomes, and then applied it to a clinical patient population. So what are the problems with the gastric augmentation? It's that you have hematuria dysuria because it's an acidic environment. It's bad for the bladder plate. You get a lot of refractory hematuria. The patients had pain, and they get this refractory metabolic alkalosis. So we all know that ileum is going to create a metabolic acidosis. It's actually pretty easy to treat. Most of the patients have a bone buffer or enough renal reserve they can buffer it. They don't require treatment. Once you get a metabolic alkalosis, it becomes really, really hard to treat. And the other thing is the stomach is really, really a strong muscle, and you don't detubularize it. So it still had rhythmic contractions. So you actually had to take a pretty as you could get from retubularized and reconfigured small or large bowel. And the other thing is that the risk of cancer, and I think we're finding this out still, the risk of cancer in the gastric segment is probably multiple times higher than any of the other augmentation gastrics or non-gastric segments we use. If we go back and look at just purely bladder augmentation, this is the first paper from Indiana where we looked at, and it's a nice play on words, the Indy 500, like a racetrack, paper. But the initial 500 patients that were done, and these were all comers. And when I look back at this paper, had a lot of troubles with how the data was interpreted in actually the way people looked at it. And this is the slide that you'll see again and again that people will use, that either if you're an optimist, 2/3 of the patients do great after an augmentation. If you're a pessimist, 1/3 of the patients are going to have problems and potentially recurring problems, some of which are life-threatening. And so I think you actually have to ask the question, does surgery matter? So indications when I was in training in the late 80s, We were doing undiversion still because some of these patients were undiverted because of kidney or renal insufficiency problems. It became really obvious these patients just needed a reconstruction. Whereas today, probably the more common indication is for a continence or a quality of life outcome. And you have to ask the question, are the indications different today? And how much does continence matter? This is a great slide that I think I kind of borrowed somehow from Bernie Churchill. And the way he approached managing these patients, I think we always have to remember that the pyramid that this creates, always kidney health, then followed by bladder preservation and bladder health, preventing infections. Those are the key components of managing these kids, whether it's surgical or medical. And then you get to kind of quality of life things, which are urinary and fecal incontinence, and then transition to independent life. But we never trade a higher function for a lower function. In other words, continence doesn't trump risk to the renal outcome over time. So the first question once we kind of started thinking about this differently, the first question we asked is, did we change the patient's life outcome? And nobody had ever done this, interestingly enough. We knew that we were doing well, but we never questioned, are we actually extending life for these patients? So this was a really nice study Konrad Szymanski kind of organized. He actually traced all 370 spina bifida patients that had had bladder augmentations and tracked down death certificates and causes of death. And it was over about 15 states that he had to look at. And what we looked at, it was interesting. If you go back and looked at patients that were born prior to 69, this is right when intermittent cath came out, they actually didn't survive initially because we didn't have great shunts. The closure wasn't as good. If you look between 69 and 70, everything else got pretty good, but you still had, gosh, about a 25 to 30% mortality really early. And a lot of this was renal mortality. But if we looked at our patients that were born between 72 and 2009, so all these patients, and looked at what caused mortality in these patients, it actually was non-renal related mortality. So if you look at, urosepsis or renal failure, it's only 4 patients. So what have we done? We've effectively allowed them to survive the renal risk and grow into other potential risks that might be fatal to them. So the next question to ask is, if we're getting them to live longer, what's their quality of life? This was our first stab at it, and again, you always learn by trying something. So this was just using a non-validated for spina bifida survey, looking at just very simply 6 questions, and then also asking them what's changed your life the most. And interestingly, the transition to needing no assistance was by far the most important thing, but also stool incontinence was a close second in this. So the next thing we did was try to develop quality of life surveys. And this took, boy, if you want to spend a couple $100,000, try to do a study like this, because you have to actually create a study, do test models, send it out internationally, and it takes a couple of years, and you have to have somebody that's really interested in doing this. Konrad Szymanski was the person to do it for us. And we actually published multiple papers that are available to you to use that had quality of life for both adults, adolescents, and kids. And it was really the first one that really looked specifically at bladder and bowel outcomes for kids. And so if you looked at the adult population, what did they care about? And it was interesting. It wasn't whether or not they had a 3-hour interval or whether they use pads. It came down to the volume of incontinence. And if you look at this, the quality of life, the higher your quality of life points, the closer you are to normal. So we would probably all score in the high 80s to 90s. We think we're doing well in our life as far as our bowel and bladder management. Boy, if you had a little bit of leakage, medium amount of leakage, or a lot of leakage, your quality of life went down dramatically, and it was statistically significant in this population. The other thing that I found very interesting in this group of patients, and again, here's the middle part where it looked at dry. It was this amount of urine that they were leaking that mattered the most. But what clearly was out of the ordinary was any bowel incontinence. It was an all or nothing. If you had any bowel incontinence, your quality of life was probably worse immediately than if you were just soaking wet. And the other surprising thing is this was age dependent. So my initial approach to these patients is, boy, when you go off to school, you need to be bone dry. You need to be out of your diapers. And you hear that again and again when you listen to parents. My child has to go to preschool. They got to get out of diapers. How are we going to do that, doc? And so our timing of surgery was actually school age. So it was in that kind of 7, 8, 9 years, we'd start talking about doing things surgically. And some of these kids, you do the operations and they were totally disinterested. The recovery was maybe not as good because they hadn't bought into the fact that they needed to be dry yet. And this survey actually helped understand that, because if you look at urinary incontinence, quality of life, actually the 8 and 9-year-olds, and that's getting into, second, third grade and higher, the kids actually didn't care very much. But once they got into kind of that early teen years and young adult life, the urinary incontinence started to matter the same as it would in adult life. And again, fecal incontinence, this was the all or none phenomena. This actually happens really early. And so in my practice, instead of doing a Mace-Monty augmentation here at 8 years old when the urinary incontinence doesn't matter, this is where we get really aggressive. And you get aggressive with peristine enemas or cone enemas, really aggressive bowel programs to eliminate this decreased quality of life from fecal incontinence without approaching a surgical answer to this. And you want to do it all at once when they're older. So the other thing I didn't always appreciate is that my patients were going to grow up with me. This is the young me and the old me, and this is the young patient and the same patient. And they do get older, they get into adult life, and yes, they go out and get married, they get sexually active, and they have their own children. And so all these things matter differently, potentially. We followed a group of patients and we asked them what impacted their satisfaction with sexual activity with respect to urinary and fecal incontinence. And if you look at urinary incontinence, and this is specifically during sexual activity, does it matter if you're wet always, sometimes, or almost never? And again, the bother level, this is reverse of the quality of life. So you want a low score of bother. The bother index, if they're almost never, they weren't worried very much about incontinence. But if they were always incontinent, they had a big bother and a big worry. So it actually mattered a lot to the families or to the kids as young adults. And in alignment with the quality of life, if they had any stool incontinence, it was a no-go as far as their bother. They wanted no incontinence, no accidents during sexual activity. So as these kids go through these 3 phases, this is that same patient here. This is a little girl that I did a Mace-Monty aug, probably 20 years ago now. She had survived a heart defect, spinal cord closure, VP shunt, was perfectly bone dry, happy as a teenager. This is her as a young adult now with her fiance. And she actually spent a year in Italy learning design for dresses. So these kids grow up and they actually go out and they do these remarkable things. Always got to throw one fish picture. And this is my son's graduation present. We went out and caught a big old trout in southern Chile. And so this type of approach where we're entertaining surgery for dryness, again, going back, what can we do? Intermittent catheterization, that's a given. First question, do they have a good outlet? If they don't, you're left with the problem is that there's no ideal bladder outlet procedure. PP Sally wrote an article. It wasn't in a common journal, but I thought this was great because his bottom line is that there's no ideal bladder neck procedure that allows you to be dry for 3 or 4 hours like we'd expect if we were voiding normally, that wouldn't change bladder capacity or compliance, that would preserve the kidneys because you'd maintain adequate bladder pressure, allowed easy intermittent catheterization per urethra if you needed to, and it was good for life. One operation, you were done. That didn't exist. And if you look at the data, again, too many moving parts, because if you change the bladder outlet, usually change the bladder comes, as you know, in all shapes and sizes before the outlet procedure, and the impact of either augmenting or not augmenting would change the outcome of each individual bladder outlet procedure. And then again, the options change. This was a big moving target over the 15, 20, 30 years that people started looking at this. And so we don't have great long-term outcome. And the other thing that happens is the kids grow up and they move. And so families change their zip codes and they're lost to follow-up. But if you look at what our options are, and this is kind of the drop-down menu for managing the outlet. Alpha agonist, it works in a minority of patients, but it's worth a shot if you have a patient with an intermediate leak point pressure because it's non-surgical. But if you look at all the other options, the drop-down gets more invasive as you go down this list, but your outcomes improve. And so as everything in life, it costs more to get more back out of it. So bladder Rosalie looked at this when we'd done about 15, 16, and we used deflux for this, which I don't know if it's the perfect agent to use. I think probably some of the other things that are stiffer polymers might work better because the deflux injection can deform, and if you have a catheter across it, it can probably remold, and it may not be as durable because these will flatten out or leak over time, I think. And so, as expected, about 20% actually achieved with, you know, short-term follow-up, what we'd consider a good dry interval. If you do this in an antegrade fashion, it may actually be better. And I think there's a good report from Atlanta showing this. Technically, it's easier to do this, I think, because you're looking at the bladder neck versus retrograde, where you're trying to guess where the urethral and bladder neck is. And I think it's really hard to get the needle in the right spot. But antegrade, you can see right where that needle goes in, and you can watch the bladder neck occlude with the bladder partially open. And so the early results actually are much, much better than what we reported. They had about a 70% improvement. Again, small series, and the test is always over time in this. Does this big mounding effect, is it durable? And are they catheterizing it through it? Probably is the other kind of independent factor that you always have to look at. The bladder neck sling. Now, this is completely different than bladder neck slings in like adult women without myelomeningocele, because the bladder neck sling in a myelomeningocele patient has to be occlusive. So you're not just kind of elevating the pelvic floor. You actually have to wrap around the bladder neck and elevate it. And I always tell parents, what we're doing is we're kinking the bladder outlet urethral junction and occluding it and creating a pressure gradient right there. Difficult plane to get to because you're going in little girls right behind the vagina. The best approach I've found is something that Henri Lotman from Paris actually described, and it's actually creating the plane between the bladder and the vagina bluntly, and then passing it. Rather than passing a clamp blindly right at the bladder neck, you're developing the plane, and then from behind the bladder, perforating laterally on both sides. And it's a little less risky as far as entering the vagina or injuring or entering the bladder neck, I think. But if you just look, and you can use anything for this, I think. I don't know if SIS is any better or worse. This is initial results with 36 SIS slings. All these kids got augmentation. This is back in the era of the blue plate special, where they came in, they got a outlet procedure and augmentation and a Mitrophanoff. With augmentation, about 75%. If you look at that 75%, that is what I'll tell you is that's a recurring number almost no matter what you do to the outlet. Right in that 70+%, 80% for some of the procedures is about what you should expect. And it doesn't matter which series here. This is Colvert Series 2002, multi-institutional, same outcomes, about 70% success rate. If you look at multiple different people, and again, these series are all handfuls of patients, usually single institutional, you get right male or female, right about 70%. The only thing I'd say from experience is that the males that are ambulatory are the hardest ones to get a sling work. And the reason why is that you have to displace that prostatic urethra and occlude it. And it's just a little hard if they're upright and valsalvating to get that totally occlusive with just a sling. So rectus fascial sling, this is probably the best results. This is the Miami group. They had 100% augmentation. And again, most of them have Mitrophanoffs. And I think this might actually make a difference. But they hit about 86% in males and almost 90% in females. But again, 100% augmentation. And they considered it good continence, and that can be a variable outcome. They may have fixed a little bit of leakage, but it reached what the patient was satisfied with. So the next level of kind of aggression for bladder neck procedures is a bladder outlet procedure. And again, these come in all kinds of shapes and sizes. This is kind of the classic young D's that was actually developed for the extrophy patient initially and just applied to the spina bifida patient. And I think the downside of this is the same with the extrophy patient, is you end up using up a lot of the bladder base to do this. And you sometimes have to reimplant the ureter to get this long enough to actually create a long enough continence channel. And I've never considered this a bladder neck repair. I think this is a bladder neck destruction or reconstruction. I'm not sure which one it is, but you're really totally creating an obstructive type pipe is what I tell families. This is Mitchell's operation. This preserves a little bit more bladder because all you're going to do is make a kind of a V-shaped incision, pull that back into the bladder and tubularize this. And again, I don't think it matters how you do this. You're creating a long, tight tube with the hopes that the pressure generated across that is less than the pressure inside the bladder, or greater than the pressure inside the bladder. This is Kirsten Meldrum's series from the late 90s, about 30 patients, 30, 40 patients. Again, right in that 70 to 80% success rate. This is back in the era when they were putting a silastic sheath to try to wrap it rather than wrapping it with a sling or a lint procedure. And the problem here is that those sheaths are foreign bodies and they erode. So this is nothing I'd tell you to do from a bladder size. And again, these operations were developed before Mitrofanoff. So you have to put it in historical context. When Ken Kropp described this, there were not Mitrofanoff procedures widely used. He was trying to create a flap valve bladder outlet procedure that allowed catheterization potentially through it, was the initial thought. This is an anterior tube. It's really complicated. I've only done about 5 or 6 of these, and I think they're technically a real difficult exercise because you're taking an anterior bladder flap, leaving it attached to the posterior wall of the bladder outlet, tubularizing it, and then reimplanting it right between the 2 ureters. And you create this long submucosal tube here. The problem is always right here, is that you've got kind of a little bit of a tortuous junction between the reconstructed tube and the native urethra, because remember, that's right next to the prostatic urethra. It's always a little tortuous in these kids, and you're going into a man-made tube. And so the biggest problem is needing additional surgery right at the outlet of this and difficulty catheterizing the patient. And when Kropp initially described this, he augmented everybody because you are taking up so much of that bladder capacity to create the continence tube. P.P. Sally came up with a little technically easier, I think, operation. It was the same principle, that you're essentially creating a bladder tube that's in a submucosal tunnel. But the way P.P. described it, he took a little smaller anterior bladder flap and actually left the posterior wall of the bladder intact mucosa. So you're just sewing this straight down and then sewing the mucosa over the top of it. It's a little bit like the continent vesicostomy for the Mitrofanoff channel. Had the almost same results as far as outcome. Still, the problem is you're taking up a little bladder capacity to do it, and you've got this junction right here. This is a great operation, a better operation, I should say, I think, in females, because you've got that short urethra and you can create a really nice long flap. So if you look at it, and this is the Riley outcome of 50 patients, that's actually a really big, and these numbers are so small, they're almost embarrassing, but this is this was at the time the biggest combined series of these procedures. And again, most of these patients had augmentation and a lot of them had catheterizable channels. If you look at, and when you were using the old fashioned kind of what's your dry interval, about 2/3 of the kids were dry for over 8 hours, 100% of the Sallies. Remember, most of these were augmented. A lot of these leaked overnight if they had the Sally, but almost all of them required additional revisionary procedures. So what's a great patient for this procedure? Big bladder, big bladder, low pressure. So something that looks like this, that has a little bit of incontinence, you can use that as an isolated procedure. Here's the urodynamics you'd want to see, low pressure out to 400 cc's or so. She can give up a small amount of bladder capacity to create that continence tube. Last procedure that is the AUS, and we just looked at how many were done across the US in one of those big data sets, and it were about 5 a year is all in kids. It was a really, really small number. And the interesting thing that we found is that if you had one of these done, about 50% had another procedure within about 6 months. And that's what you never hear about this, is what's the revision rate, because we're getting less good at doing this because we're not doing as many sphincters, especially around the bladder neck in kids anymore. So if you look early, this is Kevin Kroner, just data from Indiana, just in the myelomeningocele group, 38 of them, 15 to 38 required an augmentation. You're going to see this again here in some other data. When Tony looked at just the outcome of all comers in AUS, it was about almost 90% dry. I personally think this is a great operation if the child can void and empty to completion without catheterization, and that is such a small subset of the kids with NDV or spina bifida that it's not used as often, I think, today because of that. But this is actually a male with epispadia. So you can see, so if you have a funneled bladder outlet, this would be somebody with a lipomeningocele or something like that, would be similar. Funneled bladder outlet, good smooth walled bladder, and a nice compliant bladder on filling. You can put that right around the bladder outlet. This is the bulbar sphincter, but this is going right here in a male. So technically it's a little harder, but you can see nice occlusion with a bladder neck cuff. And then the backup operation, if nothing else is working, is the bladder neck closure. And this is essentially closing the door. A lot of different ways to do it. This is the Toronto approach that Tony Curry, when he was there, wrote up. And essentially what you want to do, two or three things he thought were really important. One is create a bladder flap. So this flap here is this part of the urethra. This is going to come superior. And then you're going to create this space where you can close the urethra, create a space, augment down to this, and then put something in between, any kind of tissue. My personal preference is to put down almost like a sling. So you're going to bring down a myofascial flap and just sew it right to the stump of the urethra. So you create a space. You can put omentum down there or anything you choose, but I think you want some kind of bladder neck closures. The success rate is good, but you still have reoperations in a not inconsequential number of these kids. If you look at for neuropathic incontinence, this was Detroit European study. Most of them were successful, but still reoperation rate was pretty high. And again, just something in between closing and bladder neck reconstruction and sling is to actually put several of these operations together. And this is actually how I approach this today. It's called a cinch procedure. It's been around forever. If you actually look back in the 80s, it was Dixon Walker down in Florida that was actually a big proponent of this approach. So a cinch procedure, essentially, if you look at the bladder outlet, a lot of them are wide. And so essentially this is going to narrow the bladder outlet and put your sling around it in a 360-degree wrap and then elevate it, the same as we do for any sling. And the results actually are really good. These are the ones that reach 90% if you augment the patient. If you look at big series, anywhere from 70 to 90% success rate. It's an operation that I tell parents it's almost too good. Here's the outlet. You can see here why just a sling. This is a male. You can see why a sling alone wouldn't work. See how wide this bladder outlet is where the Foley's going through. But if you narrow that using like a Mitchell type procedure, and then you close this and you wrap your sling right around it, you've created already a nice narrow funnel. You've created some resistance, and you're just going to put your rectus fascial sling right around it. So this all closed. This is going to go right around the bladder neck. I leave it attached on one side so you don't have suture lines on both sides of your sling. This is a New Zealand surgeon that actually described this. So again, we mentioned earlier that bladder outlet procedures are great, but what does it do to the bladder? Almost any series, and this became a point of contention. I tell you, this is one of the things where people got up and argued with each other years ago at our AAP and our SPU meetings, because there was a big proponent from Texas that said you can just do the bladder outlet independent, irrespective of what the bladder looked like. Don't worry, we have to do it. It was actually an experiment, but I tell you, history had already done that experiment for us, because if you have high outlet resistance, destruser, external sphincter dysynergia, stricture, whatever, we know what actually happens to that bladder, and we know some of them are going to fail, and spina bifida is no different. So if you look at isolated outlet procedures, what happens to the patient over time with 2 and 3 and 4 year follow-up? Almost every study in the last 3 or 4 or 5 years has shown about anywhere from a 25 to 40, 50% need for augmentation to create a safe reservoir, because of the usual reasons we'd augment patients. So new onset reflux, recurrent pyelonephritis, really high pressures with new hydronephrosis, or persistent incontinence, despite a good outlet pressure. Okay, last thing, appendical vesicostomy. We're going to run through this really quick. Any kind of channel works. This was first described by Paul Mitrofanoff. I think he should get all the credit for this, because this revolutionized everything. Again, what did it allow us to do? It allowed us to tighten up the outlet, because it gave you an alternate way to catheterize the bladder. So you can use anything. And the Mitrofanoff principle, everything under the sun has been used. It's a tubular structure. This is one of the things that actually taught me how to be an academic surgeon, because I presented this at one of the national meetings. I thought, oh boy, we've got 100 patients. Let me go present it real quick. Immediately was uncovered by myself and others that Different types of patients, different types of procedures, short follow-up. Dave Bloom, who was the chairman at Michigan for years, was a great pediatric urologist, very thoughtful guy. He came up to me and grabbed me on the shoulder and he said, "Mark, that was really great. Show me a study in 10 years with 100 patients with all the follow-up, and actually I'll believe what you're saying, and you'll have made a real contribution." So this kind of impacted how I looked at Mitrofanov, and I use that as kind of my springboard. This is how you create a very defined academic career, something you can write a lot about, that you can study, that you can try to get good at, and you follow the patients over time. So we created big databases and just followed these kids for 2 decades. So what are the problems that you have to look at and talk to the families about? Stomal stenosis, I've always considered that a minor complication. You can fix it at the skin level, but all the other ones, angulation, leakage, trauma because of probably the angulation of the channel, obliteration, abscesses, polyps, those are probably related to catheterization troubles. Lots of ways to make the stoma. It matters what you're confident with. What I'd say is what we've learned is that if you have stenosis, we can treat that with steroids. We can treat that with a stopper to try to hold that open. I personally have gone to more and more just V-shaped flaps and letting some of the mucosa show, because in my own hands, that has the lowest rate of stenosis. But you can hide these things. Here's a double channel right here. You can barely see the one on the umbilicus, and you can barely see this one. And these things are pretty durable, even if the patients gain weight. The biggest problems will really occur underneath the skin. They sewed the bladder right to the fascia before they actually put the channel in. And so this short channel here, straight, supple bladder, that was the key to the Mitrofanov principle. We forgot it a little bit. And this is where angulation and subfascial problems, which require laparotomies to fix, occurred. So big controversy is always which type of channel was best. Was the Monty better than the Mitrofanov? Was the Casal, Tony Casal described a really long channel for people that were obese. Did this create more problems? And so in story, we finally followed enough patients. I tried to hold true to what Dave Bloom told me, 100 patients in each category. So got really close. This is the follow-up. So this is the appendixes, umbilical, non-umbilical. So we had a couple hundred here, we had 180 here, so, and about 150 here, with not quite 10 years follow-up, but some patients that were out beyond 10 years. What did we see? This is kind of that scatter plot of complications needing additional surgery. They kind of folded into several groups: appendixes, Montes, and spiral Montes to the umbilicus. You can see at 10 years, pretty significant difference. And you can see here, 5-year and 10-year follow-up, best channel is the APV. No questions asked. Almost double the problems with catheterization for subfascial revisions if you use a Monty channel. Has to do with the fact that it's man-made, man-sewn, and your hinge where the mesentery is right where that goes into the bladder. And that's where you get a little diverticula, difficulty catheterizing sometimes. The spiral Monty, the umbilicus, is a long channel. And so you have more space for the angulation and the growth of that channel. And it creates more and more trouble the longer these patients have that. So current technique, how do I do it currently? I usually put it on the anterior bladder wall. So I'm going to put the channel, this is through a little tiny incision where you're just going to do an isolated Mace Monty type procedure. And here's the Monty channel already done. You can just pull that bowel out, harvest it, and reconstruct it right there. And you're going to do an extravesical reimplant, just like you're going to reimplant a ureter. So there's the extravesical channel. There's your mucosal channel. You're just going to sew that in. And you can do that through a really tiny incision. All right, we got about 15 minutes left. I'm going to run through bladder augmentation. Before I do that, my 2 cents on whether we're using Botox correctly. This is the Botox usage in the US based on the FIS database. As you can see, it's just going up and up and up over about a 10-year period. This is the patient you want to use it on. Overactive bladder, smaller capacity, and I'd say you want to do it early. We haven't affected the augmentation rate. This is that same time period, but I think you gotta look out about 5 or 10 years to see, are we impacting it? Because that's when you're gonna see it. So part of the early problem is I don't think we were very good at it. This is a patient I did a Monty on after doing the Botox. You can see most of that Botox, which I put methylene blue in, is actually outside the bladder, not in where it's gonna work. Here's an example of where Botox isn't going to work. That's a terminal change in the bladder right there. So that's poor compliance, but that's already got, collagen implanted, elastin, it's already changed. That's a stiff bladder. You're not going to get a good outcome from that, whether you Botox that, and you're going to actually get or rather need an augmentation over time. So back to Peter Metcalf's 66%, I'd say actually what we know today is that's not really true. That was probably a great big fish story. Here's the current data, and this is all the cumulative data that we collected. It's actually 50% are going to need an additional operation. So bladder stones actually are much more common. About a third of the patients will get them over a 10 and 15 year. I think secondary augmentation, I think it's actually closer to 1% if you actually use a ileal augmentation and detubularize it. Perforation's a little bit over 8%. Bowel obstruction, the longer you have it, the longer you're going to be at risk. And we think probably depending on the type of intestinal augmentation, your risk of transitional cell or other cancer may be higher. So we're going to go straight to what's the outcome for augmentation in the spina bifida population. So these are the outcomes, just exactly what we just showed that we looked at. We looked at survival analysis. We looked at patients only born after 1972. We took out from our database all the patients that didn't have modern era spina bifida or were non-spina bifida patients, came up with 400 patients. Still a pretty big series. Median age was about 8.5 at the time of augmentation, and our follow-up was close to over 10 years in this group. And most of them had ileal augmentation, which was our current bowel segment of choice. Again, 11.2 years of follow-up. In this group, 44% had 370 different operations. And I think you got to know this number because that's an honest assessment. You got to be able to tell the family. So risk of subsequent surgery, it keeps going up and up and up. And I would say these numbers flatten out only because the numbers of patients here are pretty small at this point. But if you had more patients, I think it's going to plateau eventually because, and the one thing that won't change out here is actually the stone risk, because we'll show that the patients that I call you've lost your bladder privileges, and it's from patients that aren't taking care of it, develop hydronephrosis, or they've had multiple perforations. It's not zero, it's about 2 or 3%. This is where converting this to an ileal chimney, because you've already got your bowel segment, is actually a nice way to approach this. And they can always put that back in as an augment later if they actually get better about it and get more compliant. Your 10-year risk of stones, this is what keeps going up and up and up over time and never quite gets to zero. We looked at, did it matter how we took it out? And actually, it didn't matter how we took it out, but it mattered how the patient emptied their bladder. And this makes perfect sense. If they catheterize per urethra, it's funneling and it's draining the mucus out. Their stone rate was actually lower than if they were catheterizing from above, because you had to, essentially, you were siphoning the urine out from above, and you weren't always, I think if you look at the patients and scope them, they're not always getting all the mucus out. So their risk with a catheterizable channel for recurrent stones is a little bit higher. But the kind of the age-old adage that you were better taking these out open because you had a lower stone recurrence, I think probably has been challenged appropriately. This again was looked at. Did you have endoscopic extraction directly to the stone, or did you fragment it? Did you do it open? Did you do it percutaneously? And this is my technique of how I like to do it. I'll just put a trocar right into the bladder. I'll catheterize the channel. It gets you through and through irrigation, and you can use a nephroscope to pull out medium-sized stones and frag them and take them out. It also gives you a channel for post-op to put a suprapubic tube in and have them irrigate through and through. And I think if you do that aggressively, you will lower your early recurrence of the stones based on fragments that are retained. But this is the open versus fragmented. Really not a lot of difference at 5 and 10 years for recurrence of stones. So I think part of this is based on preference and how you did it. Not all these stones are the same. This is one that's going to get taken out open. It's a 6 centimeter stone. It's going to take you forever to fragment it. You're going to have a lot of residual fragments. These guys can be taken out anyway. It's really easy to siphon these out through a nephroscope, whereas this is the one that may be approached a lot of different ways very successfully. The biggest thing you want to do is try to prevent them from having recurrent stones. The best way to do it, this is Doug Hoosman's and a couple other articles that showed the same thing. It's irrigation, irrigation, irrigation. And it's not just 50 or 60 cc's. It's actually 200 cc's a day that you had to get to. That's this top line. If you got the patient to do that, you lowered your stone recurrence rate to about 10% with almost 250 Cs of irrigation daily. Whereas if you're doing it with 60, you continue to have recurrence as you get out about 10 years. How about re-augmentation? Again, some of this data comes from the original series, and there were some holes in the original series, full disclosure. Some of these patients just had a sigmoid segment that was opened and sewn onto the bladder, not reconfigured the way we'd currently do it. If you look at just ileal augmentations, it's much lower. I'll show you that slide, but this is the 400 patients. So if you look at need for re-augmentation, it happens early and it tends to flatten out, is what I'd say is probably the best answer. This is a coordinated series between Cincinnati Children's and Riley that Brian Vanderbrink wrote up. And again, it's almost flat in this series, so a little less than 1% with over 150 patients. When do you need to do it? This is a perfect example. Native bladder, augmented bladder. This is an hourglass deformity. These never empty because you're siphoning out of here, but you've got another reservoir in the augment that doesn't drain very well. And this is the post-void residual, recurring stones and infections as a usual presentation for these patients. The other potential consequence of augmentation is actually metabolic. So we talked just very briefly about the metabolic acidosis, easy to treat, low risk unless the patient has renal insufficiency. So I actually don't even necessarily worry about that. We check that every year. I can't remember the last time I've actually treated a patient for that. B12, though, is a real problem. If you look at the early results, and there's some European data that suggests this as well, it's about 20% if you follow these kids. And when does it happen? Well, your B12 stores actually are about 6 or 7 years in your bone stores. So you don't start seeing actually B12 deficiency in most patients until about 6 or 7 years out, unless they come in vitamin deficient. Now, this is easy to treat. You can give them oral B12 supplements. You can see this is the before and after. Almost everybody had increased B12 levels up into what we consider a normal range. The biggest problem is compliance of taking the medicine, because they got to take that B12 every day, and most patients are going to fall off the bandwagon. So a lot of these patients end up getting shots if they were really, really low. But again, something to follow in these patients, part of the routine follow-up that you're going to want to establish if you have patients like this in your practice. And then the two potential lethal complications, obviously augmentation. This is, a lot of these were case series. This is just something we had. We had 3 patients out of 400. All 3 presented with terrible metastatic disease, high-grade tumors. These were all transitional cell. You can see adenocarcinoma as well. Doug Hoosman had, I think, the best to date, because he randomized the patients into 2 groups with and without augmentation. He age matched them and he followed them over time. And what he saw was that actually with neuropathic bladder, there wasn't much difference. We know that just intermittent catheter of having having a cancer occur. And if you have an augmentation without any other risk factors like smoking, it was essentially the same as if you had a native bladder. Now, extra-fee and valve patients, much, much higher risk. So when you look at the data on this, you have to separate these 3 risk groups to actually analyze the data correctly. Nephrogenic adenomas, these are nuisances. These are usually related to recurring infections or trauma. These are not been shown to be cancerous over time. And then bladder perforation. This is the silence, the chaos theory. This is somewhat related to patient compliance, I think. This is also a risk factor that never goes away. And here's a perfect example. This patient walked into clinic. This was thought to be the bladder. The bladder was actually over here. This was a contained perforation versus this patient, what looked like a little tiny leak came in and florid urosepsis. The best test is the Ct Systogram. We tried to look to see if ultrasound and variation in the amount of fluid in the abdomen would vary. It wasn't quite as sensitive as Ct Systogram. You can see here any fluid on the Ct Systogram and any contrast outside the bladder with symptoms of abdominal pain. That patient essentially has an augment rupture until you prove otherwise. Interestingly, as opposed to stones, this is an area where if you actually have a Mitrofanoff channel, it lowers your risk of perforation. And I think it's because of ease of catheterization for this group of patients. They don't have to disrobe and get out of their wheelchairs to empty their bladder. They're more likely to be timely on their catheterization. So if you actually had a bladder neck reconstruction, your risk was higher. If you CIC'd per native urethra, your risk was higher of perforation. And most of these patients, if they're spina bifida patients, they're going to have a VP shunt. If you catch them early, you might be able to manage them with drainage of the bladder and percutaneous drainage, but a lot of these kids are going to end up with laparotomy washout, closure of the perforation, and a lot of these kids, you actually have to externalize the shunt. So just skip through these kids real quickly. This is the patient. It's a good patient, good bladder. You can do almost anything to this patient. Crop, sling, they're going to end up with a good outcome. This is the patient that comes in late. They've got a bad bladder. They've already got hydronephrosis. This girl was actually managed early on very aggressively and then kind of disappeared for about 10 years with a tethered cord. She looks like she's got a good sized bladder, but her pressure is 52 and she's got reflux. And I tell you, if you have reflux, your pressure to create injury is much lower than if you don't have reflux, in my mind. We've never proven that. Great thing to study sometime in your guys' career over the future as we accrue these in multi-institutional series. But she'd already essentially lost her right kidney, and you can see the compliance curve is terrible. So even though her capacity is big, her compliance is terrible, high-grade reflux, and almost no function in that kidney. Just drainage and augment, we actually recovered that, and she did very, very well. And this is the terrible one. This is the one that we create. So this is a kid with a pretty good bladder, almost no hydro. You can do a urodynamics. You got a pretty good age expected bladder capacity. This is the kid that had the bladder neck reconstruction and sling. I did a great job. Problem is he comes back. This is his urodynamics after bladder neck reconstruction, which I always do. Has smaller volumes and incredibly high pressures now. And this is what his kidneys look like. Hydronephrosis, bilateral massive reflux. He's dry as a bone, but now his creatinine's 2 and he needs an augmentation. So again, another reason to follow these kids really closely over time. So if we augment these kids, what do you owe them for follow-up? So at a minimum, yearly renal and bladder ultrasounds. I usually get a KUB every year or two just to look for subtle stones, looking for upper tract changes. If they get a recurring UTI, this is the indication for surveillance for malignancy, and I think they need cystoscopy. If they've either got a whole bunch of recurrent infections or gross hematuria, or it's anything abnormal on the ultrasound. That was Doug Hoosman's, and I agree with him. That's your indication for endoscopic evaluation. There's not good data for surveillance endoscopically. It costs too much money to find one tumor that's fairly rare. And then I think we should get CBCs, BMP, cystatin Cs to follow yearly renal outcomes as best we can, and then B12s yearly. Terry Hensel looked at DEXA scans because if you think about what's the late risk of being hyperchloremic metabolic acidosis, in the female, it's probably actually bone demineralization. A great project would be follow these kids into their young adult life with good DEXA scans to see if early treatment of the metabolic acidosis might prevent late bone problems, since these patients are now surviving into late adult life. I'm going to skip over auto augmentation, ureteral augmentation, because that should essentially never happen. I know I'm about 5 minutes over time. We started a little bit late, so I'm going to take that 5 minute over. If you learn nothing else today, read these two books. And if I've ever been to your institution as a visiting professor, these are the two things I think that help us. So the Undoing Project, this is a book about two people that won the Nobel Prize. They're actually Israeli psychologists about decision tree analysis and decision making. There's a lot of medical stuff kind of hidden in this book, but essentially basing decisions on protocols actually creates the best outcome. They showed it, and they won actually the Nobel Prize in economics. But really good outcomes if you just follow a protocol for these patients. So I urge you to read that. And then Atul Gawande, his article, this is about his dad, actually, who was a urologist in Ohio, had metastatic prostate cancer, and decision trees around difficult decisions that the patients have to make and how those decisions may change over life as your disease process changes. And spina bifida is very much like that. So again, I'm going to end on some fish pictures. These are fish from all over the world. I always show a picture of my wife fishing with a bigger fish than I've got, hopefully. So you can, if you ever see her, please tell her I showed that picture. And then again, this has been, I think, a really nice program that UCSF has organized. Please go back and let them know your thoughts about the program by using this survey. This will be available on the website. And I think we can use this for really good CMEs in the future. And it's a good opportunity for us to have really, taped lectures that you might not otherwise have access to. There are a couple questions. So the appendical vesicostomy technique, and do I place it anterior? So even if I'm going to augment a bladder, I'm still going to place this anterior. So what I start with is I'm going to start with harvesting either the appendix or creating the Monti channel. I'm going to put that right where I want it on the anterior lateral bladder wall, because you can do that in an extravesical fashion, and you do it right where it's going to fit against the posterior fascial wall. Then I'm going to split the bladder and augment laterally. So you create the channel for the augment right where you want it, which is one of the keys to good outcomes, is having bladder, fascia, and channel all coalesce right at the hiatus. And that's going to lower your chance of needing additional surgery, I think, over time. I don't know if you guys are live or not. If you have questions that you can either ask verbally or through the Q&A or chat box, I'm happy to stay on for a couple more minutes if you've got questions. Otherwise, be safe out there. I look forward to seeing you guys all in person at some point in this next year, I hope, at a meeting. And please don't be strangers. As we have less and less meetings, we don't see each other as often, and it makes us further apart. And I think we got to really work hard when small societies to, be collegial. And so please, at the next meeting, come up and say hi, and let's have a coffee together and talk about life and urology at the same time. Michelle, do we have ability to take oral questions, or is it just in the chat box?
We can take oral questions if they raise their hand, yes.
Okay. I know you guys are all busy and back in your clinical world again, so I understand if you have to check out. But it's been great seeing you through the internet. And if there's no questions, I'll hopefully see you either next spring or next fall at the in-person meetings, guys. All right, I think we're good, Michelle.
Okay, sounds good.
Great. I'll check out. Thanks so much again. And if you could shoot me the link for this, I would love to see that and see all the other videos that everybody else has been involved with. That'd be great. Thank you so much.
Will do.
All right, you guys be safe out there, okay?